Hello everyone, this is the second lecture for the postgraduates. The title today will be the sudden sensorineural hearing loss. It is presented by Dr. Hazem Muhammad Abdel Tawab, Professor and Consultant of Otorhinolaryngology, Head and Neck Surgery, Faculty of Medicine, Cairo University, Egypt. The sudden sensorineural hearing loss is considered as a big dilemma that usually we see in our OBDs. Usually we have debates about the cause, about the definition itself, and the modality of diagnosis, or what is the proper treatment in such a case, how we consider that this patient can be treated or not, and what are the possibilities of treatment. So it's a very important subject and item that needs to be focused on. So please give me the ears. Talking about the incidence, it has been found that it can be, or it can reach up to 30 cases in the 100,000. And most of the cases of them are unilateral. It might reach about 99% a unilateral case. Presentation is bilateral, is present, but it's so rare. It usually affects the healthy, not previously ill people. And this what makes it actually a problem, because if that man is considered or that lady is considered as having previous hearing loss, that new hearing loss will not be considered in most of the cases, but usually it affects the healthy people with no complaints previously. And the most important thing is that for hearing, it affects the quality of life, especially for healthy, as I have said, the healthy individuals. So for the incidence, as we have seen in this slide, it is so important to know what is it. So first, before going for the diagnosis, why or what makes this sudden sensorineural hearing loss a dilemma? Actually, if we are going to see the definition itself, the definition itself has been seen that it is a dilemma. Like, for example, if we are going to speak about how much frequencies, how much decibels lost, in how many frequencies, for how many days, all of this will make controversies in the diagnosis. One more thing is the cause. For example, the causes of the sudden sensorineural hearing loss had been found that 90% of cases you cannot judge the cause. So again, it will be a dilemma. How can we diagnose it? This is so much important. In order to treat a thing, you need to know what was the cause and how to diagnose. If the cause is not known to you, if the method of diagnosis is not an easy one, then it will be a dilemma in treatment. And finally, how to treat it. Like all of the methods which are published or present in our practice, all of them going with the clinical experience. There is no clear evidence-based medicine which will say that you should give this one for that duration. So for these four reasons, the sudden sensorineural hearing loss is considered as a big dilemma. So definition, let's go from the scratch. Definition. According to Arellano, he had just said it's a generally unilateral sensorineural hearing loss which develops in 72 hours. By this authors and etal, he said that it's only unilateral sensorineural hearing loss, and he just considered the duration as 72 hours. While Mattox, for example, has said that it is an abrupt onset of hearing occurring at most over a few hours, so he said it's occurring about few hours, or sometimes it's occurred on awakening, like some patients awakening in the morning after their sleep, they would find that they have hearing loss. He considered this one as sudden because he had slept well, and then on the morning when he became awake, he found that he's not hearing well. Again, this is a different definition. Haberkamp and Tanieri had said different thing. They have just considered the decibels. They have said that more than 20 decibels hearing loss in more than 3 consecutive frequencies in less than 3 days. This would be a very nice definition, But going to the sudden sensorineural hearing loss research group of the Japanese Ministry of Health and Welfare comes, they have said that we are going to consider some major factors, which are the sudden onset of hearing impairment, the documented sensorineural hearing loss by an audiogram, for example, and if it is an unknown origin, because we don't know the reason or the cause. And they have also put an associated symptoms, like what? Like tinnitus, vertigo, and or nausea, vomiting, hearing loss. They said all the major features which have been mentioned here, plus all the associated symptoms must be present. At that time only, we should say that this is a definite sensorineural hearing loss. But going to the suspected sensorineural hearing loss, where they cannot just say it's a definite sensorineural hearing loss, they said that we are going to be satisfied by the major factors 1 and 2, which means that sudden onset of hearing impairment with documented sensorineural hearing loss by the investigation. Wilson said that it will be about or more than 30 decibel hearing loss, sensorineural of course, in more than or equal to 3 consecutive frequencies in less than 3 days. The evidence-based medicine actually goes with this definition. What we are meeting these days now is going with the Wilson definition for sudden sensorineural hearing loss. Causes. It's a very big table, coming with the autoimmune cases, with the circulatory vascular causes, for the infectious causes, metabolic, neoplastic, neurologic, toxic, and traumatic. But for us in ENT doctors, usually we are focusing on some of them, not all of them definitely. It's according to the presentation, it's according to the history, but usually the most important to deal with, for example, the most important is to go with, first, is the cerebellopontine angle tumors. Cerebellopontine angle tumors usually get our focus. More than that, it will be the noise exposure we should search for in the history of the patient. Ear surgery and temporal bone fractures, which are considered as a very important and very common types of trauma, as well as the alteration of the microcirculation, the vertebrobasilar, of course, and the meningococcal meningitis, which is actually can be diagnosed easily if found. Diagnosis. Going to the diagnosis of sudden sensory hearing loss, we need to first know what is our aim. Our aim is to find the cause so that we can find the treatment, and then it will not be like an idiopathic, because if you cannot find the cause, then the treatment would be difficult. But in order to know that, we should know that some of the cases are improving spontaneously. Some of the cases might reach up to 30 to 60% of the cases are improving spontaneously without any medication. What we need to know and what we need to ask about we need to know about the onset. When was it? How many days? How was it? We need to know. The baseline of hearing, because sometimes that patient is not having any documented hearing loss before or any documented hearing audiogram before, so that we are depending in the history to know what is happening to the patient. So I need to know what is the baseline level of hearing. For example, if that patient is telling me that he's having a fluctuant type of hearing loss, that sometimes it is better, sometimes it is worse, I would not consider that as a sudden. I would consider that as fluctuant, which will go more with the Meniere disease. I need to know about laterality, if it is a unilateral or bilateral, because if it is a bilateral, as we have said before, it is mostly unilateral, but if it is bilateral, we should focus about the ototoxic causes or the autoimmune causes. We should know about the level of hearing loss. Why? It's not only to know that how much we are going to treat, but it's also to predict the prognosis. As we are going to mention later, is that with more baseline or starting hearing loss, it will be of bad prognosis. Also, we should ask about vertigo and tinnitus, which might reflect also a Meniere cause, a Meniere affection. Trauma, noise, flying, diving, all of these types of trauma we need to take in consideration whenever we are asking about sudden sensory hearing loss, because all of these are causes that we need to treat, and if we find the cause, we can actually treat easily. But as we have said previously, that most of the cases we cannot identify the cause. Definitely, we should also ask about the viral infections, as we have said, the meningitis, for example, the drug ototoxicity, and the surgery to exclude the iatrogenic causes. In our clinic, what we should do in the ENT clinic whenever we see a patient with sudden sensorineural hearing loss. First of all, we need to do a complete examination of the head and neck and a thorough examination of the neurological system, especially the cranial nerves and cerebellar signs, in order to know if it is associated with syndromes or autoimmune diseases. Otoscopy. Otoscopy is needed to exclude conductive causes, for example, the middle ear effusions, the infections, and the cholesteatoma. We need to do tuning fork tests to differentiate between the conductive hearing loss and the sensorineural hearing loss. And all of us know that the tuning fork test in case of conductive hearing loss would be Rene negative, while in sensorineural hearing loss it will be either reduced positive or false negative. Fistula test is helping us to identify the perilimb fistula, which is one of the causes of a sudden sensorineural hearing loss. So this should be done in our clinics whenever we are seeing a patient with sudden sensorineural hearing loss. Then we should use our battery of investigations. For example, the audiometry. A downward sloping audiogram like this one, if it is a consistent one going like this, here, straightforward, then it would be of good prognosis rather than a down-sloping audiogram as in the picture. The down-sloping audiogram means or predicting poorer prognosis. Gadolinium MRI is very important. Why is that? According to literature, it has been found that 20% of schwannoma cases are having sudden hearing loss. And it has been found that whenever you are doing an MRI to a patient with sensorineural hearing loss, you can find up to 10% of them having schwannoma. That's why MRI is so much important in such a case, and you need to do it in the cases where you find sudden sensorineural hearing loss to exclude this schwannoma. CT scan high resolution is not the best modality. However, it can help if the MRI is contraindicated or not present, but it should be high resolution, as we have said, and it should be like thin cuts, as we have said before. It will be like 1 millimeter cuts. Investigations, lab investigations, actually from the big list of causes, we cannot just do everything. We cannot just go for full blood count. We cannot go for ESR, urea, electrolytes, lipid profile, clotting, screening, autoantibodies. We cannot do all of these. We are linked only to the patient history. So from the patient history, you should go for your investigations. And there is one truth, that's truthing, which is that the American Academy Guidelines is actually discourages the routine laboratory testing. So it depends on your good history with the patient. You should focus on some lab tests to be done, not all of them, but you should go with what you are suspecting from the patient history himself. Prognosis. Prognosis, we need to know how to predict the prognosis of such a patient, because we need to give him the expectations. Some of the patients, or most of the patients, when they are coming to our rooms, to our ENT rooms, they are asking about, am I going to be well or not? So in order to have good counseling with the patient, we need to give him according to the prognosis criteria. For example, we need to know about the time elapsed since the onset. If the patient comes to you in the first 1 day or 2 days after that, or 3 days, he can be treated. The treatment chances are higher than if the patient comes to you after 1 week or 10 days. So this is so much important. Age. If the age is over 60 years, usually this is having a poorer prognosis than a young, healthy adult. Vertigo. If the patient is having vertigo as an associated symptom, usually it's a poor prognostic factor as well. So you need also to tell your patient about that so that the expectation won't be higher. The profound hearing loss from the start. if the patient comes to you with a very high degree of hearing loss, reaching to profound hearing loss, then the prognosis would not be better than if the hearing loss was moderate to severe or even mild. The downward sloping, as I have mentioned 2 or 3 slides before, the downward sloping audiogram also is having a poor prognosis. What about the first 2 weeks? If you are giving your patient the treatment which is steroids, as we are going to mention, or either oral or intratympanic, or even hyperbaric oxygen, which are going to mention, and he did not show the improvement in the first 2 weeks, then usually the prognosis won't be as good as if he showed any degree of improvement. If your patient after 14 days of treatment is not well, is not improved even a little, it means that his prognosis will not be as good as if he is improving, and then you need to just convey the message to your patient. So from these prognosis criteria, please, all of us, we need to know and we need to discuss with our patients so that the expectations would be in a good way and in a good thinking. Treatment. Many modalities are there for the treatment, but actually if it is the identifiable cause, as we have said, meningitis, trauma, iatrogenic or accidental, if it is infection, if it is something due to the lab abnormalities, then the cause will guide you to the treatment, and the treatment modality will help you. But the problem comes if it is an idiopathic, which is the case in most of our patients. Then we need to go with the trials. As I have said before in the slides, that these patients, there is, according to our clinical experience in our clinics, we have gone with many modalities and in the literature as well. But so far, there is no complete evidence-based medicine that would say that this one is treating, or this medication is treating the sudden sensory hearing loss for 100% guarantee. Nothing like that. So we need to go with the trials according to what is there in the literature, respecting the patient, of course. Modalities, there are different modalities. Some are used in our common daily routine, and others are used less. So we need to know about these modalities. For example, if we are going to see the modalities here, for example, the anti-inflammatory steroids. We know about the steroids are the most common used group in such a case. The antiviral agents like acyclovir, if we are going to speak about a viral etiology, then linking the acyclovir with the steroids would give a benefit. Vasodilators, because some of the infections might also lead to some ischemia, and this ischemia would also affect the disease progress and might cause the problem and lead to bad prognosis. So we need to give some vasodilators. The most of them is the carbugin, of course. The volume expanders, hemodilators, and the hyperbaric oxygen, ginkgo biloba, all of these are being used, but some of them, like the steroids, the hyperbaric oxygen, are used more than the others, like acyclovir or vasodilators, in our clinical practice. So starting with the steroids, this is the most common group used, and we are going to discuss about the oral use and the intratympanic use. The oral use will be debatable. Why it is debatable? We said before that nothing in the literature says that it will help 100% guaranteed. So it is debatable. Some of the authors said that it will be effective with hearing loss between 40 and 90 decibels. This is not for sure with the other authors. It would be of benefit if it is yearly given within the first 2 weeks of the disease. If the patient comes to you or presented to you later than this, usually it will not be as beneficial as if the patient comes to you within the first 2 weeks. The dose would be 1 milligram per kilogram per day, but a maximum of 60 milligrams should be given in a single dose, and you should taper the dose later on. All of us know about the side effects of the steroids, that it might cause increase in the blood pressure, it might cause increase in the sugar levels, It might cause peptic problems, especially peptic ulcerations. So all of this should be put in consideration. Okay, what if our patients have been given the oral steroids with no benefit? And you need to see, like, for example, he had repeated the audiogram and still the hearing loss is not improved or not improved to normal levels that the patient was before. So we can give the intratympanic injection of steroids as well. So intratympanic injection can be given if failure of the oral steroids, like refractory cases, and sometimes we can also give the intratympanic injection as salvage if failure of all methods. Again, it's an evidence-lacking modality of treatment. Again, it goes with our clinical experience. The dose, it would be also different from one author to another one, but the most common used dose would be you can give 0.7 to 0.8 ml, of course, from the 4 milligrams per ml. Like we have the ampoules of 4 milligrams ml dexa methazone, then we can use 0.7 to 0.8 ml to be delivered through injection, direct injection, or through the delivery system, like, for example, it's going to be through a grommet tube. Usually, it does not need like to go to OT, to operating theater with anesthesia. Usually, local anesthesia would be beneficial, would be enough, like putting amlacrane in the ear for some time, or putting a xylocaine on the cotton and put it on the eardrum for some time, or even some of the doctors are doing, some of the physicians are doing injection local first, and then they are going for the injection in the eardrum, not to cause pain for the patient. So the delivery system, it's either direct injection or through a grommet tube to make it easy for the patient, because there should be some sessions. So there is a frequency here. The frequency will not be a one time only. Usually it goes from 2 sessions, 3, 4. Some of the authors have been said up to 6 doses weekly basis. All of this has been found in the literature with differences from one author to the other. But the most common to be used is 2 doses at least, separated by 1 week, and then you should repeat the audiogram after that. The advantage of intratympanic injection is to avoid the oral steroid side effects. And it would give higher doses in the inner ear, because you are applying the steroid directly in the middle ear. So it will be absorbed to the inner ear more concentration, and this would help the recovery of the case. But the problem with the intratympanic injection, that is also having side effects like pain, like transient dizziness, sometimes infection, sometimes persistent tympanic membrane perforation from the repeated injections or from the grommet itself if you are going to put it. Sometimes it has been found in the literature. And the possible vasovagal attack, which is actually happening with some of the patients. So we should consider all of these side effects, and whenever we are discussing the intratympanic injection with our patients, all of these side effects should be told. After the injection, what you should do? After the injection, you should tell the patient to sleep on the opposite ear for about 30 minutes and tell him to strictly avoid straining and strictly avoid forcible blowing of the nose, because he needs to be calm. He needs to stay for some time till the absorption of the fluid in the middle ear takes place to the inner ear. So after the procedure, you need to tell your patient to sleep, as I have said, on the other side for 30 minutes at least, and tell him to avoid the straining and avoid the forcible blowing of the nose. The hyperbaric oxygen as well have been used and mentioned in literature as one of the modalities for treatment. It has been adopted since 1960. Here in this modality of treatment, we are applying the oxygen in a pressure more than 1 atmosphere. Why? Because this will improve the tissue oxygenation. And of course, if tissue oxygenation will improve, it means the vascularity. It means that better chances to improve the vascularity of the nerve, and which may later on reflect on better chances for improvement. Usually, it will involve multiple sessions. Each session will be from 1 hour to 2 hours, Usually it will last for about days to sometimes weeks. Again, all of these modalities, especially the hyperbaric oxygen, still all of them not evidence-based, but they are going with the clinical experience and the research and the clinical trials that had been found in the literature. Side effects of the hyperbaric oxygen, despite rare, but they can cause damage to the middle ear. They can cause damage to the sinus mucosa and the lungs from the pressure changes. They can cause the oxygen poisoning due to the high pressure. Yet it is so expensive, and it is not found in every country, and it's not present in the old centers. So in choosing this modality, we should also tell the patient about the side effects, and we should find and tell the patient about the prices and the availability if it is there. Salvage. What about salvage treatment in such cases? Like, for example, you have given your patient all the modalities of treatment and still the patient is complaining. The salvage will be like another chance of trying to treat this patient. The one used or the most commonly used will be the intratympanic steroid injection and the hyperbaric oxygen therapy. Oral steroids had been mentioned in the literature also for the salvage, but yet the intratympanic steroid injection and the hyperbaric oxygen therapy usually avoid the side effects of oral steroids, as I mentioned before. The American Academy of Otolaryngology Head and Neck Surgery had just put some criteria for the prognosis of the patient and definition of the disease. Usually the unaffected ear should be used as a standard. Why we are saying this? Because not most of the patient will have a baseline audiogram before. Most of them will come to you as first presentation, no audiogram before, and then we should consider the other ear as the standard. If it is normal, then it will be good to measure that one with the disease, but actually it is not a very accurate method. But if you don't have a previous audiogram, then it will be helping you to know what is the level, especially if the patient have told you that they were the same before. They have just defined the complete recovery is as a return to within 10 decibel hearing loss of the unaffected ear, like returning to normal, and return of word recognition scores to within 5% to 10% in the unaffected ear. So it means that we are going to compare with the unaffected ear. It means that you are going to have at least 10 decibel hearing loss of the unaffected ear, and the word recognition will be coming back to 5% to 10% of the unaffected ear. That's why we said the unaffected ear is so much important, especially if it is normal, and especially if the patient words say that they were equal before. The partial recovery depends on what? Depends on whether or not the degree of initial hearing loss made the ear not serviceable hearing. The no recovery. They have defined the no recovery as anything less than 10 decibel hearing loss improvement. It should be classified as no recovery. The take-home message of this lecture would be: many causes of sensorineural hearing loss exist, yet about 90%, as we have said, are idiopathic and not known well, which makes it as dilemma in diagnosis. The MRI is a must. You should need it to exclude retrocochlear lesion, and in the centers where MRI is not available, or if the patient is having any contraindication to MRI, you should do a CT scan high resolution contrasted with thin cuts, 1 millimeter cuts, as mentioned before. Oral steroids, intratympanic steroid injection, and hyperbaric oxygen therapy have been used in such cases with advantages as well as side effects. This is a very important subject that we are meeting in our clinics, and we should know about it and know about the patient criteria, how to counsel the patient, how to make the expectations of our patients realistic, how to tell them about the modalities of treatment. All of this would help us in management of sudden sensorineural hearing loss. And this is the end of this lecture, and thank you so much.